Hi, welcome to NEET PG Core Revision Series in Pharmacology, where I will be taking you through the most important topics asked in the NEET PG examinations, and this is going to help you in your upcoming NEET PG preparation as well. So, we are going to do today the drugs for cough and bronchial asthma. So, starting with what are the important drugs that you should know about the anti-cough drugs, right? So we have, the cough can be two types, either it is productive or if it is dry. So remember, for a productive cough, we are always, our aim is to, so that you can spit out or excrete out whatever the secretions are there. Because if you keep them inside, then, or if you do not, or if you try to suppress them, that will increase the chances of infection. So you want to cough out the secretions. But dry cough usually is very irritating, and we try to just suppress that dry cough. So let's do the drugs for productive cough. So we have two types. One is expectorant, and we have mucolytics. So in expectorants we have guaifenesin, and in mucolytics we have N-acetylcysteine, number one, and number two we have bromhexine, and we have pembroxyl. So what is N-acetylcysteine going to do for us? N-acetylcysteine is going to break the disulfide bonds in the mucoproteins. And when it does this, it is going to decrease the viscosity or the thickness of the secretions. So what is going to happen? It is easy to cough it out. Then bromhexine, what it does is that bromhexine tries to, or it does, depolymerize the mucopolysaccharides. Mucopolysaccharide fibers, and this also decreases the viscosity. So it makes the secretions less viscous to cough out. Decrease the viscosity of the secretions. Now ambroxyl, actually it is a metabolite of bromhexine. So it does what bromhexine does, plus additionally it also increases the clearance of these secretions. So it increases the mucociliary clearance. So this is the main role of the drugs which are used in cases of productive cough. Moving on to the drugs which are used for dry cough. So here we have basically the drugs which are going to target the cough center. So they inhibit the medullary center, and they are going to suppress the cough reflex. So these are your antitussive drugs. So they are called as antitussive drugs. So they can be, number one, opioids like codeine, folcodeine, hydrocodone. Okay. Then we have non-opioids, because opioids have a problem of addiction. Addiction potential is there. So these non-opioids are free from that addiction potential. So non-opioids which are more preferred: noscapine, dextromethorphan. So dextromethorphan, what is the mechanism? It inhibits the NMDA receptor. Third, we have antihistamines. Allergic cough can be there. So antihistamines like diphenhydramine, promethazine, and then we also have, apart from this, we have peripheral or peripherally acting drugs, peripherally acting drugs. So they act at the peripheral level, they suppress the cough impulses at the peripheral level. So peripherally acting drugs. So here we have a drug levodropropizine. Levodropropizine. So these are the drugs which are used for the management of cough, and many a time it can happen that the cough is because of bronchoconstriction. So we need to add a bronchodilator. So various syrups that we have, the cough syrups, they also sometimes contain the bronchodilators like salbutamol. That can take care of the feature of the cough if it is because of bronchoconstriction. Now moving on to the drugs for bronchial asthma. So we are first going to classify them. So what happens when there is bronchoconstriction in bronchial asthma? So there is increase in the hyperreactivity and there is constriction leading to cough, difficulty in breathing. So first and foremost, we need bronchodilators there, right? So bronchodilators, number one, we have the specific β₂ agonist. So specific β₂ agonist, we have short acting, long acting, and also we have a very long acting beta agonists. So in the short acting ones, we have salbutamol, terbutaline, and pentobarbital, LABA. So wherever there is metro, formoterol, salmeterol, and bambuterol, so where there is a longer name, formoterol, so there these are the longer acting ones. Then we have very long acting ones. So in very long acting ones, we have olodaterol and indacaterol, even longer. So these are the specific beta-2 agonists. Then we have methylxanthines like theophylline, doxyphylline, aminophylline, anticholinergics, ipratropium, tiotropium, magnesium sulfate. Then the other group we have mast cell stabilizers and stabilize the mast cells like sodium chromoglycate and ketotifen. Then we have leukotriene antagonists like montelukast, zafirlukast, corticosteroids, hydrocortisone, prednisolone, anti-immunoglobulin E antibody which is omalizumab, and this is usually we give for persistent asthma. Now remember, we have certain newer drugs also, monoclonal antibodies against these specific interleukins 5 and 4. So interleukin 5, remember, it is associated with the the eosinophils. It is associated with it triggers the eosinophils. Activates the eosinophils mainly. And interleukin 4 is responsible for IgE antibody production. So therefore, they play a role in this asthma. So these three groups of drugs, they are used for treatment of severe eosinophilic asthma, right? Severe eosinophilic asthma. Now, the first is anti-IL, interleukin 5 antibody, which is mepolizumab and reslizumab, right? So remember, Li means interleukins here, you can see Li, Li, Li. So these are interleukins, you can remember. So they are against a particular interleukin. So there are two interleukins. One is interleukin 5 and the other is interleukin 4. Now, interleukin 5 is the main interleukin which is concerned with eosinophils here. So this Li means interleukin. Now which interleukin? So pollen, also you can say POL rhymes with pollen. So pollen, you know that allergy is because of the eosinophils, and eosinophilic interleukin is interleukin 5. Rest, you can say that there is you can, there is rash. Rest will rhyme with rash. There is rash. Rash is there in allergy. Allergy again, eosinophils you can see, and again interleukin 5. So this way you can make an association. So mepolizumab has a pollen in this, so it will be against interleukin 5. Then reslizumab with RES, remember rash. So rash is there because of the allergy, and that is also again associated with interleukin 5, that is eosinophil. Then we have benralizumab. Now here interestingly, so this is Li is interleukin and R is you consider as receptor. So this is benrali. Okay? So Li, this is interleukin. R you consider as a receptor, and Ben, remember we have a character called as Ben 10. So half of this is 5. So Ben 10, half of this is 5. So this is an interleukin 5 receptor antibody. This was interleukin 5, the ligand. This is against the receptor. So benralizumab, interleukin, R is receptor. So remember Ben 10 is like half of 10 is 5. So interleukin 5 receptor antibody, right? So this is how you can remember. Then we have anti-interleukin 4 receptor antibody. So here we have dupilumab. So dupilumab you can remember, dupi is duplicate or duplicate of 2. Du is duo 2. So when we duplicate 2, it becomes 4. So this is against the interleukin 4. So this is a way of remembering and associating how to remember, because there are so many monoclonal antibodies out there. Very difficult to remember a lot of them, but few we can remember if we put similar associations with them. So here mepolizumab, reslizumab, benralizumab, dupilumab. Now this benralizumab was a previous year question as well. So that's why this is how you can associate and remember them. Alright, so moving on to these drugs, number 1 is the what are the drugs that we can give if there is acute asthma, and which drugs are given in case of chronic asthma. So remember, whenever there is an acute attack of asthma, the first thing we need to do is we take care of the bronchodilatation, because that will relieve the patient immediately. So here we use bronchodilators. So bronchodilators of choice we have selective β₂-agonists, right? β₂-agonists, other bronchodilators we have are your anticholinergics. Then we have methylxanthines, and we have magnesium sulfate. So all these are given to take care of the acute attack of asthma. Remember, currently along with the β₂-agonists, we also start now inhalational corticosteroids, because they are going to decrease the inflammation and enhance the effect of β₂-agonists. So otherwise, chronically, we give corticosteroids as such. We start it, but also it is given for some time. So chronic asthma, we have corticosteroids. Now mast cell stabilizer. So once there is an attack of asthma, then these drugs don't work, because once your mast cell, they have released the mediators, then there is no fun of giving mast cell stabilizers, because an attack has already occurred. So you can prevent the attack of asthma by giving a mast cell stabilizer beforehand, when the months are approaching or those particular season is approaching, when there is more pollen and the patient is the patient usually has that kind of an attack. So you can preventively start 1 month before by giving mast cell stabilizers. Similarly, leukotriene antagonists, because in asthma there is release of leukotrienes and they act on the receptors, leukotriene receptors. So you give a leukotriene receptor antagonist beforehand, so that even if the leukotrienes are released, they will not be able to act on their receptors. But once the attack is there, again these kind of drugs, they will not be of any value to us. Then lipooxygenase inhibitors. Remember, when we did that arachidonic acid, it has 2 pathways. One is the COX, metabolism of arachidonic acid occurs by COX pathway, and the other is the LOX pathway. So COX pathway is associated with formation of prostaglandins, thromboxane A2, and the LOX pathway, it leads to formation of leukotrienes B4 and all rest. So this is the pathway which is responsible for the asthma attack, right? So leukotrienes are going to lead to the asthma. So either you inhibit this like lipooxygenase, so leukotrienes are not formed, or when even if the leukotrienes are formed, you need to give receptor antagonist so that these leukotrienes don't go and bind to this receptor. So any of this will work, but again these are preventive methods. Then monoclonal antibodies. So all these monoclonal antibodies, because they take a time to act, so again these are also used for chronic cases of asthma, right? So this is, we have a picture in mind that which drugs will be effective in acute and which drugs are going to work in chronic asthma. So moving on to the first group, we have sympathomimetics here. So sympathomimetics, β₂ agonists. Most important are β₂ agonists. So we have short acting β₂ agonists like we did sal, butamolta, butylene, etc. So they work or they last for around 4 to 6 hours. The action will last for around 4 to 6 hours. Then long acting beta agonists like formoterol and salmeterol. Now remember that these drugs, they will produce the effect for about 12 hours, but their onset is also very late. So you cannot give for immediate when you want to immediately acute attack needs to be suppressed, but yes, for nocturnal prophylaxis or for nocturnal asthma there you can give. But here the exception to the rule is formoterol. So this formoterol is FF means fast. So its onset of action also is quick. So currently for acute asthma, the drug of choice for us is formoterol because it is solving two problems. Number one, it is acting quickly. Number two, it will last for a long period of time. So we do not need to give the shorter acting ones because we have to repeat them after every 4 to 6 hours. So here the mechanism of action is such that it works for about 12 hours. So formoterol we usually we can start for the acute attack, and along with this we give inhalational corticosteroids, right? Then very long acting, definitely these are only you can say reserved for prophylaxis, not for immediate attack. So we have olodaterol and indacaterol. So they work for around 24 hours, right? So we use them mostly, they are used in not alone but in combination with inhalational corticosteroids. So these drugs are used in combination with inhalational corticosteroids. So there was a drug initially, clenbuterol, but now it is no longer used. Why? Because of it was abused because of its anabolic action. Anabolic action, it got banned because of it. Then the next bronchodilator we have are your anticholinergics because they block the M3 receptors. Now these anticholinergic drugs are the drug of choice for COPD because there the cholinergic tone is very high, or in people who are on beta blockers. Their beta-2 agonist won't work, or people who are on beta blockers. So we have short acting drugs like tiotropium and ipratropium, right? So tiotropium and ipratropium. Then we have long acting drugs like eclidinium. Now this is the longest acting, and umeclidinium, right? So these drugs are longer acting ones. So remember there was a question asked in the previous year that what is the paradoxical bronchoconstriction which is seen with these drugs, the short acting ones, especially the ipratropium. So ipratropium bromide, it can cause paradoxical bronchoconstriction. These are bronchodilators, but it causes paradoxical bronchoconstriction. Why? Now what happens here is that, so this is the innervation or innervating the nerve that is releasing the acetylcholine, right? So here we have the lungs and we have the receptors, the muscarinic receptors here. So here also we have a receptor on the presynaptic neuron and we have a receptor on the effector organ as such. So here the receptor is M3 and here we have the M2 receptor. We know that the receptor which are actually present where on the presynaptic neuron, they're always, whenever they are stimulated, they are going to decrease the release of neurotransmitter because they are brakes. Whenever you stimulate them, they apply brake and acetylcholine will not able to release. So when you give drugs like ipratropium, because it is not very selective for M3, it also acts on M2. So because it acts on M2, it will cause a transient increase. M2, you are blocking the M2 now, so you are releasing the brake. So there is going to be a transient increase in the acetylcholine. This acetylcholine is responsible for the brief bronchoconstriction. Then later on it is going to act on M3 and then it is causing bronchodilation. But this transient bronchoconstriction is because of the action on the M2 receptors. Now this is not seen with tiotropium. Why? Because tiotropium is selective for M3. So this is mostly seen with ipratropium bromide. Moving on to theophylline, another very important drug for examination point of view, very often asked. So theophylline, it has a narrow therapeutic index, so the range should be between 5 to 20 microgram per ml, right? It follows zero order kinetics or the enzyme saturation kinetics, example of that. Now how it works? Now theophylline has a bronchodilator property also and it has an anti-inflammatory action also. So bronchodilator property is by number 1, it is a phosphodiesterase 3 inhibitor. It inhibits mostly phosphodiesterase 3 as compared to phosphodiesterase 4 mainly. That is one way of causing bronchodilation. Number 2, it also inhibits the adenosine 1 receptor, because adenosine receptor is associated with bronchoconstriction. So when you block this receptor, there is bronchodilation. Now how is the anti-inflammatory action coming about? This is because of increase in the histone deacetylase in the airway inflammatory cells. Inflammatory cells. So this is the way how the anti-inflammatory action comes into picture. So two actions. Now another very important question which is asked usually are the ADRs of aminophyllin or theophylline. Now it shows certain ADRs because of phosphodiesterase inhibition, certain ADRs because of A1 inhibition, and certain ADRs are because of combination of the both. So what ADRs are there because of the phosphodiesterase inhibition? So remember P and D. So let's see. P, you remember, for pet. Pet in Hindi means the stomach. So the pet in Hindi means the stomach, right? And in the stomach, it causes nausea and vomiting. D means damag. So remember, damag means brain, so it causes headache. So this is how you associate. So P and D, pet and damag, stomach and the brain, nausea, vomiting, headache because of this. What is left with us is that it can cause diuresis and it can cause seizures. Okay, diuresis and seizures. You can also remember here SAD. Seizures, A1 and diuresis. Then due to both it can cause arrhythmia. Right? So this is how you can remember the various side effects which is associated with various receptors. Then leukotriene antagonist, they are going to be used, as I told you, prophylactically only. Prophylaxis for chronic persistent asthma. The main ADRs we should be worried about is hepatotoxicity and Churg-Strauss syndrome. Okay. Mast cell stabilizers like ketotifen and sodium chromoglycate. So what are they going to do? they are going to stabilize the mast cell so that the mediators, they don't release. That is the role of mast cell stabilizers. Okay, and even one more is nidochromil. Okay, then moving on to the steroids. Now, steroids that we mostly use are the inhalational corticosteroids. Until and unless there is refractory asthma, we prefer to give inhalational corticosteroids because one, they will directly target the organ site and they will have less of systemic side effects are less. So, we have beclomethasone and budesonide. So, these are your drug of choice for the asthma which is persistent, right? And they are used along with formoterol in case of acute attack of the asthma, right? Now, fluticasone is one of the most potent drug here. Then we have triamcinolone and cyclosinide. Remember, for cyclosinide, this is a soft steroid. Soft steroid means it is a steroid. It's actually a prodrug and it changes into the active form, in the lung, right? It is activated only in the lung. Therefore, it has less tendency to cause the oral thrush. So, therefore, there is no oral thrush seen with this. Okay. The oral steroids like prednisolone, this is given only in case of refractory asthma. Otherwise, we give inhalational steroids. This is only in case of refractory asthma. IV steroid is hydrocortisone. So, we give IV hydrocortisone 100 milligrams. Now, this is given in case of status asthmaticus, right? Status asthmaticus. Now, ADRs of steroids, especially the inhalation which are more common, what is this? Number one, it leads to oral thrush or oral candidiasis, right? So, to prevent this, what we tell the patient is that every time they take an inhaler or the puff, they need to rinse their mouth, and secondly, they can use spacers. So, you can decrease the way or decrease the occurrence of oral candidiasis. But if it occurs, what is the treatment? You give the antifungal nystatin or you can give clotrimazole, right? So, these are the antifungals which can be given topically. Number two, the most common ADR that we can see with this is hoarseness of voice. That's the most common. So, these two, oral candidiasis, hoarseness of voice, you must know the ADRs for this. So, management of asthma as such, if we talk about, is that for acute attack, please remember, we give formoterol and we start concurrently inhalational corticosteroids. For prophylaxis or chronic asthma, what we do? We add on drugs like leukotriene receptor antagonists, or we can add on theophylline because if it is not getting controlled. So, these are the important drugs that you must know from the topic of cough and drugs for bronchial asthma. Thank you so much.